Hi, everyone, and welcome to the Evidence-Based Birth webinar, all about the evidence on Pitocin. If you're watching the recording, you might want to forward past some of the intro where we're getting settled in. We're welcoming, hopefully, a lot of people here today. I know we had a record number of people register for this webinar, so looking forward to seeing so many of you here, and thank you for taking time out of your busy schedule to hang out with us tonight and geek out about the research evidence. Give us just a minute to get our panelists all lined up, and we will get started with the teaching in a minute. In the meantime, I'm going to put up a couple polls while you're waiting for us to get started, so feel free to participate in the polls if you like. And we got Aaron here. Aaron's on. Aaron, can you do a quick mic check? Just say hi, everyone.
Hi, everyone. How do I sound?
You sound great. All right.
Okay, awesome.
And Ihotu is here. Hi, Ihotu.
Hi.
So we are so excited to talk with you all tonight. We opened the room a little bit early, so it's still 1 minute before we're officially supposed to start. Yeah, go ahead and introduce yourself in the chat box, but make sure that you change the little blue button if you're on your computer to say everyone, and then type your intro. Let us know where you're joining from, how you're feeling today, if you're excited to be here. And we also wanted to let you know that we will be having, let me see, I'm going to manage one thing real quick, get our translation started. So we do have an interpreter tonight for Spanish if you would prefer to listen in Spanish, and I need to get the transcription turned on as well. So there will be closed captions. All right, hopefully that should be working. We got a ton of people here. Technically haven't even started yet, and the room is halfway filled up. Welcome, everyone. We got some students. I'm going to go ahead and end the poll and share the results. Wow, we have a lot of new people here today. So 65%, this is their first webinar with EBB. So welcome to all the newbies. We're excited to have you here. And I have another question for you all. So let me stop sharing that and let us know, what's your role in the healthcare system? Are you a childbirth educator, parent or parent-to-be, doula, nurse, midwife, physician, student, or other? If you're an other, put it in the chat. We will be getting started in just a minute. Okay. Shantae, let me know. Shantae says good. She knows me. Okay, so let's see who's here today. All right, Ihotu and Aaron, we've got half the room is doulas, so that's exciting. 47%. Love all the doulas here. We got a lot of nurses, midwives, parents and parents-to-be, childbirth educators, and students, and lactation consultants. Oh, that's what I was missing on that list. We've got people from all over the world here today. Any first-time parents here who are expecting their first baby or getting ready to give birth for the first time? Let us know in the chat if you want to share. Me, not me. Somebody said that, not me. All right. Let's see. The other question. Oh, I had one more question while we're waiting for everybody to get in the room. Which best describes your relationship to EBB? Are you an instructor, pro member, podcast listener, parent or parent-to-be, general public? And we did have a private showing for our pro members yesterday, but some of them may be here today, and some of our instructors as well. Some people just found out they're expecting. Congratulations to everyone who's having a baby soon. We're so thrilled for you. And we're excited to share some information and hopefully demystify one of these medical interventions that there seems to be a lot of anxiety about. So hopefully we can help people understand this a little bit better. Oh yeah, remember one more time to hit the blue button in the chat and to so that we can all see your chat comments. Otherwise, it just goes to me, Aaron, and Ihotu, and we might not see it. So it looks like we have a lot of podcast listeners today. About half of the people here are podcast listeners. That's awesome. We have some really fun episodes coming up over the next month. Okay. Aaron and Ihotu, are you two ready? All right. We do have the transcription at the bottom of the video and live Spanish translation. So if you prefer to listen in Spanish, please click the translation button. And then there's always a recording with closed captions that will be available on YouTube after this. And all of those things are working. So I want to introduce the EBB research team. Hi everyone, my name is Dr. Rebecca Decker. I'm the founder at EBB and one of our research editors. And Ihotu and Aaron, do you want to briefly introduce yourselves? Say hi.
Who will go first? Okay. My name is Ihotu Ali. I'm hailing from Dakota Land here in Minnesota, Twin Cities. I use she, her pronouns. Longtime doula and public health researcher and student chiropractor, massage therapist as well.
I'm Erin. I'm a research editor here as well. I also use she, her pronouns, and Ihotu and I have a kind of a similar background. I was a clinical researcher turned doula and childbirth educator, and now living up in the mountains in Colorado. And I see lots of Coloradans in the chat. So hi, Colorado people.
So today we're going to talk about Pitocin. I do have to go through the disclaimer first that watching this webinar does not mean we are in a patient care provider relationship, that we're not giving medical advice. We encourage you to talk with your care provider if you have concerns or you want to put some of this into practice. We do our best, but the content is not guaranteed to be 100% accurate. And a quick content note, we will be talking about interventions, cesareans, uterine rupture, and we are doing a little play at the end of this presentation where there will be coercion from a doctor. So if you're worried that might bother you, you could tune out at that time. You are welcome to take a few screenshots or to take like a 10-second video to share on social media. You can tag us at EBBirth on Instagram or TikTok, and Aaron and Ihotu and I are going to wave in case you want to take a picture. We're waving. Yay. All right, we're getting started. So how will today's webinar work? We're going to do some teaching. Our team has split it up, and I'm doing the intro, and then Ihotu speaking, then me again, then Aaron. And then we will do some info about where you can get more resources. We'll do a short Q&A, and then at the very end, we will provide all of today's notes in a handout for you. So we will give you the link at the end of the webinar. We'll also email it out afterwards. So if you have to leave early, we understand, but we'll give you that link to the notes from this webinar with all the references. So I have a poll for you as well. Let me pull that up. How confident do you feel in your knowledge of Pitocin or synthetic oxytocin on a scale of 0 to 5? 0 being not confident at all, and 5 being extremely confident I could teach this class, in which case maybe we should trade. Give one of us the night off. Okay. All the answers are coming in. Almost everybody's responding. That's great. I'm going to end the poll and share the results. And oh, there's a nice little bell curve there. So it looks like we have some people who feel like they don't know everything. A few people feel like they know it all. And then we have a bunch of people in the middle who feel like they could build their confidence. So that's, you know, all of us, hopefully my goal is that you will leave today with at least one thing that's like an aha moment or takeaway for you. Even if you feel like you know a lot about Pitocin, we hope you learn something new tonight. We certainly did when we were putting this presentation together. Another question I have for you all, what percentage of your friends or clients or family do you feel like receive Pitocin during birth for either labor induction or augmentation? Let us know in the poll, and I'll give everybody a chance to kind of just do a guess or an estimate. And oh wow, I get a preview of these results. These are fascinating. So I'll share them with you. And looks like almost everybody's responded. So I'm going to end the poll. And wow, that's fascinating. So a lot of you picked 50 or 75%, and even 16% of you picked 90 to 100%. That's a lot of people who are witnessing being Pitocin used a lot. So it just goes to show you this is an extremely common intervention, and hopefully we will be able to share more info with you. One more poll question. What percentage of, have you heard about the shortage of synthetic oxytocin? Put your answer in the poll. We kind of want to see what's going on with you. And if you do have a shortage, put it in the chat where you're located, where you're seeing the shortage. Okay. I'm going to go ahead and close down the response and share the results. Okay, so a lot of people have not heard of it. 24% of you have heard it's coming, and 10% have said it's coming. So some people are seeing it. Quebec, other parts of Canada, all over the United States. So there's already shortages happening in a lot of people's areas. So, and this is a screenshot of one of the pharmaceutical companies that makes synthetic oxytocin, just kind of like notifying their customers. And you can Google synthetic oxytocin shortage and find other information about it. It looks like it's going to affect both the kind of Pitocin in the larger bottles that they use for induction and augmentation, and the smaller bottles that they use in postpartum. And one of the reasons you might not have seen the shortage yet in North America, if you haven't heard of it yet, it's because they have to use up everything that's going to expire. So a lot of places are acting as if things are normal, but once they've used up that lot and there's an expiration, then there's going to be a shortage. And this company is recommending that their hospital customers use severe conservation measures. So something to think about. It looks like this will be a problem November and December, and then hopefully resolved in January. So we're going to help you learn the evidence on oxytocin, which we're talking about your own natural oxytocin, and then synthetic oxytocin, which we'll call Pitocin sometimes, and sometimes we'll call it synthetic oxytocin. And this is the three major points we're going to cover. All about oxytocin, which Ihotu is going to teach. I'm going to teach Pitocin for induction, and Erin's going to teach Pitocin for augmentation. And then in about an hour, all we have is this 1 hour together. We might go 10 minutes over, but we're going to be talking about these issues. There's a lot of topics we're not going to be able to get to, so I'm going to point you to resources where you can go to learn more. So we'll do that before we let you go. All right, so first, some background. So Pitocin is also known as synthetic oxytocin. It's a form of the hormone oxytocin, and it's given as a generic intravenous drug. Sometimes you'll hear hospital staff simply call it oxytocin, and that is its generic name. And it's also given under the brand names Pitocin and Syntocinon, and it's used in most labor inductions, but it's also used to augment or strengthen labor, and it's used postpartum, like right before the birth of the placenta a lot of the time. We're going to be focusing on those first two uses, during induction and during augmentation. So spontaneous labor, just so we're all using the same terms and definitions, is when uterine contractions start on their own and that they result in cervical change. So you're not using medications to start labor. Augmented labor is when you have a spontaneous labor that started on its own, but then you go on to use medicine or artificial rupture of membranes to increase the frequency or strength of contractions. And then induced labor is using medicine or other methods to start regular labor contractions. All right, Ihotu, it's you.
Right, let's talk about oxytocin. We're going to go over some science and some history, so get ready to nerd out with me here. We'll start out with a question. So, what words, thoughts, feelings come to mind when you think about Pitocin? Let's go ahead and write them into the chat. What just immediately comes to mind? Stream of consciousness here. Okay, so avoid pain. I saw pain several times. Oof. Okay. Yeah. Hemorrhage, intensity. Okay, painful contractions. So keep those coming. That's a lot. I just want to kind of breathe into that space of pain and pressure and the intensity. I've seen intensity a few times. Yeah, strong labor. So let's kind of breathe, reel that back in a little bit. And let's talk about, so oxytocin is something that exists in our bodies, right? All the time. You know, depending on what you're doing this moment, you might be releasing oxytocin if you're having a great time, if you're, you know, rubbing up on somebody. So let's talk about where it comes from inside of the body before we talk about what's happening in the birth room. If you've been in talks with me before, you know that I'm a body worker. I do abdominal massage, chiropractic. I like to use my hands. So I'm going to have us all bring our fingers up and go ahead and put one finger on the space between and just above your eyebrows. So some will call this the third eye. Yes, love hormone. Behind that finger, deep in the center of your brain, there's a structure called the hypothalamus. And the hypothalamus is a coordinating center of the brain between the hormonal system and the nervous system. And it releases one hormone called oxytocin, right? And so I've already seen it in the chat. And that's when I first learned about oxytocin many years ago as a doula, we called it the love hormone or the cuddle hormone. So studies show that oxytocin releases during orgasm, releases during labor, nipple stimulation. It causes the uterus to contract, the cervix to relax and open, and breast milk cells to contract and eject out the milk. It has effects on sexual activity, relaxation, pain relief, social bonding, trust and protection behaviors. So just to juxtapose that from what we saw in the chat, oxytocin really has a lot of pain relief and kind of like relaxation elements to it. Feeling protected, feeling maternal, right? And so researchers have found that giving someone a spray of oxytocin through the nostril raises trust during money gains, raises trust among strangers. It's been shown to increase this kind of protective behavior in animals, even among young that they did not birth. So unfortunately, we cannot buy oxytocin over the counter in stores, although we may really want to at times. You can imagine kind of the public health implications of if we could all just be taking this endogenous form of oxytocin to reduce times of heightened stress and fear, right? And then one point I want to note with the spray. So oxytocin is first, when it's released from the hypothalamus, it's released first into the brain, and then it passes out of the kind of cerebrospinal fluid into the bloodstream. Once it goes into the bloodstream, it can't come back into the brain. And those behavioral effects of oxytocin, the reduction of anxiety and stress and pain relief, comes from oxytocin being in the brain. And so we will come back to that later when we talk about how Pitocin is different from oxytocin. Yeah, we can go to the next slide. So if you're already like nerding out with me right now, this is a great book to check out. Dr. Uvnaz Moberg is a Swedish physician and pharmacist with her PhD in physiology. And this book is a really nice review of all the animal and human research that has ever been done on oxytocin up to the time of publication. I want to give a heads up, though, that it has a lot of gendered language in this book and speaks a lot about mothers. If you don't identify as mother, just a heads up. But oxytocin, great research resource. Okay, so let's look at a little bit of history. People have been trying to induce labor for as long as we know. Labor was induced for all kinds of reasons, from fetal demise to rickets, to keeping the parent comfortable, and toxemia, preeclampsia. there were midwives who, from many different cultures, would use different remedies to try to induce contractions. So they would use, one of the most effective herbs that they used was called ergot. And ergot was a fungus that grew on rye, and it comes from the word argot or cockspur because it looked like the red feathers on a rooster's head. So there had been epidemics from fields infested with ergot that caused gangrene and death, and the midwives were noticing that people who had the disease often miscarried. So they're thinking maybe if we give a powder in very small doses to people who had prolonged labor with no progress, that might induce contractions. So ergot was used by midwives in areas of current day France and Germany. In the 1700s, physicians started publishing about it, and it was reported as coming to the United States by a physician who learned it from a Scottish midwife. Unfortunately, there were side effects. Extremely strong contractions could happen, uterine ruptures could happen with the use of ergot. So they're looking at what else we can do. Amniotomy was also risky because it could cause infection. And other options that were looked at during that time were herbal teas, enemas, and even bloodletting. So in general, there was kind of this missing piece. There was a huge need for some kind of drug or something that could be used to induce or augment contractions safely and that could be really precisely controlled. So let's look at Henry Dale. British physiologist Henry Dale was the first to isolate the active ingredient of ergot, which is ergometrin. He was using cat models and found that you could take the extract from the pituitary gland of an ox to cause contractions in pregnant cats, right? These are the studies. And he named it oxytocin, which is close to the Greek word for swift birth. So zooming forward a little bit, in 1913, more doctors had started giving this extract of animal pituitary glands to induce labor inductions. Vincent Duvigneau was an American chemist in Illinois who found that the pituitary extract contained two different hormones, oxytocin and vasopressin. And he went on to actually create a synthetic version of oxytocin that was identical to the natural endogenous oxytocin. This is actually the very first successful synthesis of a polypeptide hormone. This is the first synthetic hormone. It was an incredible achievement. You can see this is basically the recipe right here. You want to make some at home in your kitchen lab. And he published this chemical configuration of oxytocin and won the Nobel Prize for his contributions to medicine. Just want to note that this was an all-white team of scientists. There was one woman on the team, Charlotte Ressler, who, as far as we can tell, is the only member of his team still alive today. So big things in 1954. So synthetic Pitocin was given initially as a shot, or it's shot in the muscle or shot right under the skin. But there were still these cases of uterine rupture, much like what was happening with ergot. So by the 1950s, Pitocin was starting to be given by IV directly into the bloodstream with better results because it could be more precisely controlled. So this is something to keep an eye out for, is how closely your Pitocin levels are monitored. And the other thing to note here, as I kind of wrap up, is remember that those behavioral effects come from when oxytocin is released from the hypothalamus in the brain. Pitocin is coming in through the bloodstream. So that's one major difference. Pitocin cannot cross that blood-brain barrier. And that means we don't get the same level of all the good things, the stress reduction and the pain relief and all those protective kind of nurturing behaviors. But the rest is really history. IV Pitocin was considered much more safe at this point, safer than ergot, safer than pituitary extracts, or intramuscular doses, although that's still given for the third stage. And we see it as it is today, very popular for inductions and augmentation.
Thank you, Ihotu. I think it's so, there's so much fear related to Pitocin. I think it's important to remember that it is an advancement in medicine that we didn't used to have. And if you have an urgent reason to have the birth now or a medical emergency, it can be way safer than what we used to have and much more effective. The problem is, of course, we're going to talk about is it's overused. So like, it's still by itself a tool. It doesn't have to be associated with all these negative things that we associate it with. And so we're going to talk about the evidence on Pitocin for induction. And as Ihotu said, Pitocin, Oxytocin, they're actually identical in chemical structure. And one of the things that we haven't really mentioned yet is that Pitocin can cause more frequent, longer, and more painful contractions when it is given, especially in high doses. Your normal own oxytocin is released in pulses, and then it's broken down in between the pulses. So your brain releases exactly kind of like what you need, and then it's broken down. That gives your uterus a break. And when we're giving Pitocin IV, we're not doing that. There is some research on giving it in pulses, but not showing very promising results. There's a big word at the bottom of this slide. It's called receptor desensitization. If you can see my video right now, I'm not sure if, there we go. So the uterus has all these little receptors that are sticking out of the cell surfaces. Oxytocin floats around, attaches to that receptor. Having too high doses of Pitocin for too long is like having a whole bunch of neighbors that keep knocking on your door, and eventually you get tired of your neighbors and you stop answering the door. That's what happens with receptor desensitization. Your receptors say, I'm tired, I'm not going to answer the door anymore, and they stop responding to the oxytocin. When that happens, that can cause abnormal contractions, and it can cause postpartum hemorrhage. So one question
Rebecca,
yeah,
some folks are asking you to turn up, and I don't want them to miss your awesome explanation because I love the neighbor analogy.
That happened last time. I can't turn up the volume on my microphone. I can switch my microphone and see if you get a better results. Is this one better? Can you hear me better? Okay. All right.
I hear you louder. Yep, they're saying yes. Okay. Sorry to interrupt.
Quick repeat of that. Hopefully the transcription was catching it though. Your uterus has receptors, and it's like having, if you have too much oxytocin floating around, it's like having neighbors that are always knocking at your door over and over, and you get tired of your neighbors. So you pretend like you're not home and you don't answer the door. That's what happens with receptor desensitization. There's been too much Pitocin in the bloodstream, and your uterus stops answering the door, essentially, and you can have actually a decrease in contractions, abnormal contractions, and potentially postpartum hemorrhage. So that was the question then leading to that. One of the things that can prevent that is to use low dose Pitocin in induction. So I wanted to know if you all could answer this poll question. If you're a birth worker, I know some parents might not know how to answer this question, but birth workers should be able to answer it. Do you typically see low dose or high dose Pitocin? And if you see high dose, could you put where you're located, or is it only with specific providers? So if you typically see high dose, where are you seeing it? Texas, Michigan, San Francisco, Kentucky, Michigan, Utah. Okay, so Vietnam, it seems like there's a variation. There's not a specific part of the United States, at least. So it looks like most people are saying they see low dose Pitocin, which is great. That's what you want to see. Although I bet some of you, even if you said you normally see low dose, you still see high dose with certain practitioners, and that can be a problem. So we're going to talk about that. So another researcher around the same time that Pitocin came into being was Dr. Bishop. And Dr. Bishop popularized elective inductions because he was able to determine which of his patients would be most likely to have a successful induction. And so the score that he used went on to become known as the Bishop score, where you rate different aspects of the cervix readiness for induction. And they found that you get a really good results with an induction if your score is 8 or greater. If it's 6 or less, it means the cervix is not ready, and there probably needs to be some cervical ripening happening before you start Pitocin. With this, Dr. Bishop was able to have extremely low cesarean rates with his inductions, very successful inductions. But many studies have found that induction with Pitocin alone is really not that effective. You have to have, if your cervix is not ripened, you have to have cervical ripening, which we've talked about in a couple podcasts in the last year at Evidence-Based Birth. And it's not evidence-based to use synthetic oxytocin by itself in someone with a Bishop score of 6 or less. So if you come in and they just hook you up to Pitocin and your Bishop score was 6 or lower, that's not evidence-based. And then one big meta-analysis where they combine other studies found that if you have a favorable cervix, if your cervix is ready to go into labor, synthetic oxytocin plus amniotomy, which is breaking the bag of waters, is the method most likely to achieve vaginal birth in 24 hours. So it's actually one situation where if you combine these two interventions, you have better results than if you just use either one alone. Another combination method, so Pitocin is very unlikely to work all by itself. It's like you need to have these other things going along with it. Another combo method is Foley plus Pitocin. A Foley is a catheter that's typically used in the bladder, but they can use it in labor and delivery. The balloon there that you see would be deflated. You would insert that into your, through your vagina, into your cervix, into the uterus. They would blow up that balloon with saline and then pull down gently to kind of put some pressure on the top of your cervix. That kind of helps with, mechanically helps ripen your cervix. And there is research that using both of those together is more effective if it's your first birth. So some advantages of the synthetic oxytocin. Right now it's widely available, although we were just talking about the shortage, but it's the most common medication used for induction. So healthcare workers are usually pretty familiar and well-trained in using it. If or once the cervix is ripe, combining synthetic oxytocin with amniotomy is the most effective induction method compared to all the other methods. But there are a lot of disadvantages. Synthetic oxytocin is what we call a high alert medication, meaning that if a drug mistake or drug error occurred, it could be life-threatening. It's also the drug most often linked to preventable complications and lawsuits due to when it is misused or there's a mistake made with it. So there are specific safety protocols that healthcare workers are supposed to use when they're giving synthetic oxytocin. The most frequent side effect is tachysystole. That is when the uterus is contracting too much, too quickly. And it can be typically resolved by turning the oxytocin off. One rare side effect is uterine rupture. The risk is very low if you've never had a C-section before, but if you have a scar on your uterus and you've had a history of prior cesarean and you attempt a VBAC, the risk with Pitocin is higher, so it's 1 in 100. And then other side effects include fetal compromise. In other words, if the baby's not getting enough oxygen because the uterus is contracting too much, placental abruption, low blood sodium, low blood pressure, and it can also cause swelling. Some more disadvantages. The strong and frequent contractions from Pitocin may make it more likely that you're going to need pain medications, and then you could have side effects from the pain medications. Prolonged use can increase the risk of postpartum hemorrhage because of that receptor downregulation we talked about earlier. It requires continuous in-person monitoring and one-to-one nursing care. Whether or not that's provided is another story, but you're supposed to have one nurse assigned to one patient. Most facilities will not permit you to get in the tub if you're on synthetic oxytocin. And it also limits mobility because you're tethered to an IV pole. And then there is research showing that Pitocin can cause conflict between like doctors and nurses. Say, for example, the doctor wants to be more aggressive with the Pitocin and the nurse does not. That can create conflict, but there are standard protocols now that are supposed to help reduce that conflict. So the low versus high dose is still controversial. It shouldn't be. But the problem is that ACOG, the American College of Obstetricians and Gynecologists, still recommends low or high dose regimens. They say that either is okay. AWAN, which is the Nursing Association in the United States, recommends a low dose regimen starting at 0.5 to 2 milliunits. In contrast to high dose regimen might be like 4 to 6. You start at 4 to 6. And research shows that when you start at that higher dose, it increases the risk of tachysystole without improving the cesarean rate. So you basically have more side effects with no benefits. And a lot of you are familiar with the ARRIVE study. There was another analysis done on that looking at Pitocin, and they found worse newborn outcomes with mid to high dose regimens and no improvement in cesarean rates. So really the high dose regimen should be avoided. A few more notes before I pass it on to Erin. Once active labor is established, it's really important that the synthetic oxytocin be turned off or turned down to prevent receptor downregulation, especially if you're having a long labor induction. So once you get into active labor, 6 or more centimeters, they should turn off the Pitocin and let you labor without it. And you should go on to have a normal labor without it. The problem is that they keep giving it, which then can cause abnormalities. It's also important for nurses to not, there's something called pit through the pattern, which means that there's an abnormal pattern, you just keep the pit going, you just keep it going. And that's a myth. Too much Pitocin can lead to frequent low intensity contractions, coupling or tripling of contractions where they're just like stacked on top of one another, and tachysystole. And if any abnormalities occur, you have to have a 30 to 60 minute break from, turn it off, let the Pitocin leave your system. It leaves your system fairly quickly within about 10 minutes. And you also probably need IV fluids. And then some people, when they restart it at a lower dose. All right, Erin, I'm gonna turn it to you to talk about augmentation.
Okay, great, thank you. I am going to talk about the evidence on Pitocin augmentation. So before we get started, I'd love to ask everyone some reasons that you see care providers recommend Pitocin when somebody's already in labor. And you can just type your comments right in the chat like you all have been doing. Seeing tons of things.
Yeah, lots of slow labor. They've had an epidural. They're not being patient. They want to move things along. The clock is going. They want to make it faster.
Okay, great. Well, everyone feel free to keep on typing your answers, and I'm going to give a little explanation for those that don't know about what augmentation is. So augmenting labor means using synthetic oxytocin, or Pitocin as we're calling it, to speed up labor. It could also mean artificially breaking the bag of waters. For the webinar today, obviously we're focusing on Pitocin, so that's what I'm going to talk about more specifically. So there's a lot of variation, a lot of different reasons why this happens. And there's also a lot of different timing and different dosing. So there's no real consensus. Some care providers, and this was really news to me as I started researching this topic, are just standard practice wanting to actively manage labor and encourage it along. Others are hoping to speed it up or get it going again after it's stalled out, as a lot of you are alluding to in the comments. This method works by a care provider making the recommendation usually, and Pitocin, for those that are not birth workers, Pitocin is administered through an IV like Rebecca has talked about. And once a birthing person is receiving Pitocin, it means that that person and their baby must be monitored continuously. And we've talked a little bit about high dose versus low dose protocols already, but just to give a little bit of clarity there, a care provider will start generally with a lower dose, and and then they'll increase that dose every 30 to 60 minutes. And they will generally keep on increasing until they reach the desired contraction pattern. So until somebody's in active labor and having contractions every few minutes. So there's some variation still when we talk about high versus low dose protocols. A lot of people were asking this in the chat. But when we talk about low dose, we're generally meaning that they're starting at 1 to 2 millunits a minute. And talking about high dose, we mean starting higher than that. So generally 3 or above millunits a minute. And then following that same plan of increasing slowly over time until the patient gets into active labor. So like so many of the things that we talk about here at EBB, this whole idea of augmenting or medically managing a labor can be traced back to this one major study, and it's called Active Management of Labor. So the study was carried out in 1973 by O'Driscoll and colleagues, and it was at the National Maternity Hospital in Dublin, Ireland. And there was really no medical rationale for doing this study. The entire goal was efficiency in the hospital. And the study followed a really strict protocol that we're going to get a little bit more into. So this is just a screenshot. It's an image of the original study, the way that it looked when it was published in the British Medical Journal about 50 years ago. So looking a little closer at the protocol, here's an overview. The study enrolled 1,000 consecutive patients, and all of them were giving birth for the first time. The patients had to be in labor prior to being admitted to the hospital. They had to have continuous one-on-one nursing support, and they had Pitocin and AROM if cervical change was less than 1 centimeter an hour over a period of 2 hours. And the study had a really low cesarean rate. It was about 5%. So when we look a little bit more closely at this research, there's some things that aren't initially clear when you just look at the results. So the first thing is that there were 1,000 patients, like I mentioned, and only about half of them got Pitocin. The other half of them progressed on their own at the desired rate that they were going for in this study. And another thing we want to point out is that about half the patients had no pain medication at all, and about half of them had opioids. Only 13 out of the total of 1,000 had epidurals. So this is one reason that maybe we see labor moving along more quickly in this study than we're used to today, because epidurals are known to sometimes slow down labor, and hardly anyone in this study had one. But the crazy thing is, it's really just this. We base our use of Pitocin on this one small study. It's not even a randomized trial, and only about 500 patients total got Pitocin. So some more recent research that we want to talk about, we looked at a bunch of different studies focusing on Pitocin augmentation, and we pulled 3 that we wanted to summarize, and we created a little table that you all have in your handouts, and it goes a little bit more specifically into the details of each of these studies. So your handout will show for each of these studies when it took place, the population, what the researchers were looking at or comparing, the results, and then on the far right, we have any special notes that we had on the study, if there are any. So just to talk briefly about the major results from the 3 studies, the first one is a meta-analysis of 4 studies. So it's not new research, but it's combining the results of 4 studies that were previously done. And all of the studies looked at the differences in outcome between high dose and low dose Pitocin augmentation. And they found no difference in outcome between when a high dose and a low dose were used for Pitocin augmentation. The second study is a population-based study. So it's a survey that was done in France at 7 different maternity wards of over 7,000 people. And this study was specifically looking at when and why Pitocin was used to augment labor. And so there were strict criteria that the investigators were looking at to see if Pitocin was being used correctly. And what they saw was that Pitocin was misused about 21% of the time. People were having their labors augmented when the labor wasn't meeting the definition of a slow labor that necessitated augmentation. And then the third study that we reviewed, it's the one double-blinded randomized trial of the group. This one, again, was looking at high dose versus low dose Pitocin for augmentation. And what they found was that although high dose could shorten the overall length of labor just slightly, so by about 30 minutes, the high dose Pitocin had more side effects like hyperstimulation of the uterus, which could lead to abnormal fetal heart tracing. And so also important, high dose didn't have the desired outcome that they were looking for. It didn't lower the cesarean rate. It just had the potential of slowing down labor a little bit, but again, with side effects. So something that we talked about as a research team a lot while we were going through all these studies is that, to our knowledge, and we've looked a lot, there is no randomized control trial that looks at augmenting labor with Pitocin versus just waiting. So most of the studies that we reviewed, if they were looking at Pitocin, compared high dose and low dose, but we didn't find research that looks at Pitocin versus not Pitocin. So that's a huge gap that we see. So here's that table that I mentioned. If anybody wants to dig a little bit deeper into these 3 studies that I've just reviewed and learn a little bit more, there's a copy of it in your handout. So bottom line on Pitocin for augmentation, higher dose Pitocin can decrease the length of labor slightly as compared to low dose Pitocin, but high dose may cause more uterine hyperstimulation, which can lead to abnormal fetal heart tracings. And also many labors are augmented without a medical reason. So next up, we are going to do our advocacy role play exercise.
I changed into scrubs for the role for this little play. Everybody loves our lovely labor and delivery suite. We're gonna quick do this little play for you, and we need our doctor. She's changing into her doctor costume. Erin's got her comfy hoodie on, and who else do we have? Allie, you gonna turn your camera on, Allie? Wait, is it Allie or is it somebody else? Oh, Allie's here. Okay, Allie's rocking it. Okay. Okay. Are you all ready for our play, our evidence-based birth play? This is a little advocacy play for you all. It's short and sweet, but it's good. I'm the nurse, and Erin is in labor. Allie is the partner, and Ihotu is the doctor. Okay. Ihotu, are you cool? I see your camera's off. Just making sure. Okay. Go ahead and turn your microphones
I'm
on.
off stage.
Okay, you're off. Yeah, you can be off stage. All right. Well, Erin, you haven't progressed in the past 3 hours, so the doctor says we're going to start a drip.
Can you tell me more?
It's really recommended that we start this. It's called Pitocin. It'll help you progress faster.
I'm not interested right now.
Oh, I'm going to stop sharing my screen so you all can see it. You're not interested? Well, we really need to get this started soon. I'll have the doctor come talk with you.
So, Erin, you're not progressing as fast as we would like. If you want to have a vaginal birth, we're going to have to get the ball rolling.
I want to do a quick pause here. I'll also be the narrator. Erin knows her options already because she's educated. She took a childbirth class. She knows she can clear the room by saying she needs to pray. She can say she wants to go to the bathroom. She can request more information. She can say she'll use something else to help labor progress. She could say yes to the Pitocin, or she could just say no. And she's going to ask her partner to relay their choice.
Well, we understand, and we'd like to have some more time to use other ways of helping labor progress. We have our doula here, and I think we're good.
I'm all for doulas, but that won't be as effective as the Pitocin, and we really need to get the ball rolling.
Okay, I appreciate what you're saying and what you're telling us, but give us a second, we'll think about it. And if for some reason these alternatives don't work, we would be open to Pitocin at a later time. Right, babe?
Okay, I'm so sorry. But if you want to have a healthy baby, you really need to follow this medical advice.
Right. Yeah. We're all on the same team here. We totally understand and we're concerned about safety. But at this point, we're going to decline the Pitocin. And if you'd like to mark that in your chart, if that's going to make you feel comfortable with this, that you educated us on the risks of declining Pitocin, we're fine with that. But we are making an informed refusal.
Okay. I see that you're really not interested in getting things going. But if that is your decision, I will mark it in my chart. Good luck.
Yay! Thank you, everyone. So yes, that was our little play, and I know some of you were saying, "Wow, that was triggering." We did do a trigger warning. Some people might have missed that, but I think Allie and Aaron did great, right? I think Allie was really protecting Aaron there, right? Taking the bulk of the heavy duty lifting of dealing with the doctor who is just trying to do her job, right? And I think Allie realized that, we are all on the same team. And so what were some methods that Aaron and Allie used in that situation where they were feeling pressure? Yeah, some people are saying it was realistic and other people are like, does it really happen like this? And yes, it can happen. That's why we were able to write this role play and get it so spot on, where some of you were like, oh, I've seen this conversation. So what other things? I didn't give into the fear mongering, stayed calm, didn't, talk about informed refusal, understood the risks, said we're on the same team. It took time. They used yes and, so instead of saying no, definitely not, she was like, yes, we thank you for this information and we're going to do something different. Didn't give her power away. Laura says good communication skills. This is the importance of an informed partner. I love how Aaron could just like lay back and relax, right? Isn't that what you should do?
I have a really good partner.
Yeah. Yeah. So let me see if there's anything I'm forgetting with the techniques.
I'm gonna no longer be the snarky doctor now.
Yeah. Pitocin is in doctoral school and she's going to be a wonderful doctor. So it was
Not
hard
all
to play
doctors.
that role.
I'm not all doctors. I'm just the worst ones for that play.
Yeah. So you see, like, here's our script. Partner says, we understand and we would like to have time to use other ways of helping. This is all going to be in your handout. So if you want some of this scripting that the parents use, it's in your handout. And I really appreciate this information and I'll think about it. And then if you notice this, the partner did something important that I don't think anybody picked out. The partner let the doctor save face, which when you're in a negotiating situation, letting someone save face and walk away with their dignity intact is important. So by saying, you can blame it on us, mark it in our chart that we were informed and we still refused it, like that lets Dr. Ali walk away feeling like, well, at least I did my job, right? Yeah, I got it on the paper chart. So those were some of this is all in your handout. As well. And paying attention to your own endogenous oxytocin, like, Allie could have ramped it up a little bit more and pushed back harder, but she was able to manage it in that situation so that Aaron's, stress levels didn't go up. So today we covered all about oxytocin, Pitocin for induction, Pitocin for augmentation. I'd love to know in the chat, what's your number one takeaway? We're going to talk about resources. We'll do the Q&A and then the handout. And then while I'm getting ready to do that, go ahead and tell me in the chat, what's your number one takeaway? And I'll see what's going on in the chat. The handout we'll give you the link at the end. It will also get emailed to you. Let's see. Pitocin should be stopped in active labor. Advocacy. the value of your partner being supportive and informed, the Pitocin protocol based on one lousy study, informed refusal, do not pit through the pattern. Pitocin doesn't cross the blood-brain barrier, you can refuse it. Laura says, I no longer feel alone after reading the chat. Pitocin's a tool that can be misused just like other tools. Low versus high. It doesn't relieve pain because it's not in the brain. And it's not bad when it's used when necessary. And I hope we got that point across as well, that it can be, you know, a drug that's needed. And as we may see with this upcoming shortage, like some people will be hurt if we don't have access to it. And so I think what you're going to see first is a lot of elective use of Pitocin stopped. And it's only going to be used for medical reasons, which is probably how it should be in many cases. Yeah, based on one small study. And yeah, lots of historical context. Awesome. Okay. So some resources where you can go to learn more if this kind of like made you thirsty for more information. We have more information. So some people were asking about Pitocin when it's given during the third stage of labor for the birth of the placenta. We have a whole article on that, evidencebasedbirth.com/third stage. Also for our pro members, we have a full hour-long training on that topic. And then also failure to progress, we recently updated. That was Aaron's big project this year. And there's a lot of info in there on how to help labor progress if it feels like it's slowing down. And we also have a handout on that page with definitions of what's normal and abnormal so that you can know, is it reasonable to use Pitocin now? We talk about induction for a bunch of different reasons at EBB. Here are two of them, big baby and due dates. So knowing the evidence on that can be really helpful. And then if you want to search more, just go to that main evidence-based birth website, click on blog. You can use the search box. Also, one thing I like to tell people is if you click on this filter, you can see our different series. There's one filter that says signature articles. Click on that and you get all of our full-length, like peer-reviewed, evidence-based articles. Then the podcast, this is all in your handout as well. So it'll all be in your handout. These are some podcast episodes we thought would be helpful for those of you who want to learn more about Pitocin, labor progress. What can you do if you're being induced? How do you navigate that? What are some ways you can help labor progress without Pitocin? And so that is in your handout there. If you're expecting a baby and you're interested, we do have the evidence-based birth childbirth class, and you can attend in person, hybrid, or totally virtually with an instructor. And you can check that out at evidencebasedbirth.com/childbirth class. We also have a pro membership, which is kind of like our main thing that we do here at EBB behind the scenes is work on supporting our members. So these are birth workers who want to make a true impact in their community, and they want a supportive interprofessional environment where they don't feel like they're alone, because as we were talking about, it can be really stressful to be a doula and be in the room when situations like that are happening. So we try to provide a lot of trainings and support for our members. Our members get all of our continuing education courses and the continuing ed certificates that go with it, the live monthly trainings and the recordings, a private community with access to Team EBB. So if you had a question that wasn't answered today, you can post it in our member community and Aaron, Ihotu, or I will answer it. We have a library of all of our PDF handouts, interactive videos, and sneak peeks of articles and topics. So the continuing ed inside the membership is good for nurses. We have nursing contact hours, and then doulas and childbirth educators can also use those nursing contact hours. And then we have contact hours good for midwives, nurse midwives, and the midwifery bridge certificate. So the big news is that we have heard what people are asking for, and we have dropped the price for the next week by $20 a month, and also quite a bit on the annual price as well. We also have scholarships available. So I'm going to have Shantae or one of our other team members drop the link in the chat if you're interested in taking advantage of this price. This is the best deal we've offered. in a long time. So it's a great opportunity if you want to try it out to lock in that price. So that would be your price for the lifetime that you're a member, unless you quit. So, and you can cancel at any time. So how to join at the reduced rate? We will have the link there. You just click on the link, you choose if you want to do monthly. It should automatically apply the coupon code, but if it doesn't, it's there on your handout, or you can choose annually and you'll automatically get access. And you would also, the members will get a contact hour for this training. So that is inside the membership academy. Okay, so now I'm going to do, we have a few minutes where we can do a Q&A, and then we'll have the handout link after the Q&A. There have been so many amazing questions, and our team has been compiling these questions, and Aaron and Ihoti are going to help me. So I'm going to throw some questions out there. Hold on. I've been talking for a while, so somebody else needs to go with the first question. All right. Some people are asking about, does Pitocin does it harm breastfeeding? Who wants to take that?
I can take that one. I have a few notes prepared on breastfeeding. Well, what we know about endogenous oxytocin is that it's a big part of breastfeeding and chest feeding because of bonding, and its impact on the letdown, the rejection, ejection reflex. It doesn't have impact on milk production. That's a different hormone, but it helps with bonding in general. So endogenously has a big part to play there. In terms of Pitocin, synthetic oxytocin, there was a big study of 50,000 participants in 2009 that really raised an alarm on if Pitocin can have a negative impact on breastfeeding. This was a big study that found at 48 hours postpartum, breastfeeding rates were lower for those who had received labor meds, including Pitocin. So generally what I've seen, the worry, the concern, a little bit of anxiety is, what if you take synthetic oxytocin, and that reduces your endogenous levels of oxytocin, which could impact milk letdown, baby sucking reflexes, disturbing the golden hour of alertness, first hour after birth, or having problems with the uterus. So the state of the evidence currently is mixed. There's a big study, Erickson 2017, that did a review of 26 studies looking over the last 40 years. 50% of those studies found that actually, yes, there was an association between lower breastfeeding rates and Pitocin use. 50% of the studies found that there's no association. There were no studies that found that Pitocin would be helpful for breastfeeding. So that's really the mixed state of the evidence. It could be that there's some kind of difference in terms of different people responding differently to Pitocin, but the evidence is mixed.
Okay, so semi-related to that, there was one about long-term effects on the baby, and I can take that one because I have taught a class on that. And so far, there were some people are dropping some links to different videos and such, but I think you have to be really careful when you're looking at the news articles or research on Pitocin and long-term effects, because a lot of those studies are really bad quality that I'll read through one time and I can see like 50 things wrong with that study. And the main thing that's wrong with those studies is that they don't look at other risk factors. So, for example, a few studies found an association between synthetic oxytocin and autism diagnoses later in childhood. And news reporters got a hold of that and started, publishing articles about how terrible this is. But none of those studies controlled for family history, which is like the number one factor. So, and they didn't do sibling or cousin comparisons. And then a very large study published in 2020 found that any proposed relationship between synthetic oxytocin and different neurodevelopment conditions was almost completely eliminated when you properly controlled for risk factors like family history. So I think you just have to take all that information with a huge grain of salt. Let's see. Another question. There's so many good ones. Was there one on VBAC? Aaron, did you do that one? Did you do that research on feedback?
That was
I think EHO2 did, but I can talk about it a little bit too if you want.
Okay.
EHO2, what do you
I
think?
can start, and if you have anything to add.
Okay. that
Sounds good.
Okay. Well, so what I found is, we know the evidence shows there's an increased risk at high doses. We've been talking about that, right? And so clinical guidelines from AWON, the Association of Women's Health, Obstetric and Neonatal Nurses, and also the Society of Obstetricians and Gynecologists of Canada, those guidelines state that Pitocin can be used for induction and augmentation for VBAC, or trials of labor after a cesarean, as long as it's really carefully monitored, it doesn't go above 20 milliunits per minute. So this is coming mostly from a study from 2021 by Zhang et al., which was a review of 14 studies, collectively 48,000 participants, where they found uterine rupture rates to be 3 times higher for any amount of oxytocin use versus no oxytocin use. And then the concern for high doses comes from a 2008 study where researchers found this risk of uterine rupture goes up, and they recommend that maximum of 20 milliunits per minute. The Canadian guidelines also state that pregnant people should be informed that induction is linked to a lower VBAC rate and compared to spontaneous labor. And then the other last note I would just add is when we're looking at induction, it's important to look at what medications are used. For example, misoprostol is found in the literature to have a higher risk of uterine rupture than oxytocin. Does that sound?
Yeah, that's really helpful.
I
Aaron,
read the exact same stuff you too, so I don't have anything to
we were
add.
trying to prepare. Yeah, we kind of knew in advance what people might be curious about. Aaron, though, I know you've helped with the premature rupture membranes. Somebody asked, what about Pitocin after your water has broken and labor hasn't started? Is that evidence-based?
Yeah, so I saw a lot of people put that in the comments too about when labor was being augmented. So there's a specific study that looks at that, and it's called Term Prom. And we looked at that when we were preparing for this webinar a lot. And so in this one, they looked at a bunch of people who had spontaneous rupture of membranes at 37 weeks and beyond. And these patients got randomized to either get induced immediately with Pitocin or with prostaglandin. So in the US, the brand name that you might hear is Cervidil, or the other group went to expectant management. So they got nothing. And in the expectant management group, they actually allowed 4 days for labor to start, which is much longer than anything I've ever seen in practice. But if after 4 days, the patients didn't go into labor on their own, then they got randomized again to either get Pitocin or prostaglandin. And so what they saw in this study was that the rate of infection was about the same, whether people were in the expectant management group or whether they were induced right away. And the cesarean rate was about the same also. So the cesarean rate was about 10%, whether they waited around for several days for labor to start, or they induced with Pitocin or with prostaglandin. So not evidence-based to give Pitocin right away to somebody according to the results of this study. Something that we noted when we read this, and we talked about this in the pro member preview yesterday, was this kind of bias that existed where in the expectant management group, more people got sent, more babies were sent to the NICU, even though the rates of infection were about the same. So there's this idea that knowing that the bag of waters had been broken for a longer time made more care providers send babies into the NICU. And also possible that those people had more exams, more vaginal exams, because they were there waiting around for much longer and they had their water broken. But yeah, so that's what Term Prom says. It was an interesting study to read.
Okay. And I see, like, I've seen so many people ask about postpartum depression. So I'm going to do that one, then I think we'll wrap it up. So does Pitocin increase the risk of postpartum depression? And I have answered this question before, and I've looked at all the research, so I can answer this one. Postpartum depression affects about 10 to 15% of people. And the known risk factors for PPD include family history, your own psychiatric history and history of past depression, adverse life events, trauma, and insufficient social support. So there is some emerging research that if you have higher natural oxytocin levels in late pregnancy and the postpartum period, that's correlated with better mood and less anxiety and depression. And this makes sense because oxytocin is one of the feel-good hormones. On the other hand, lower levels of oxytocin toward the end of pregnancy are related to higher levels of postpartum depression after birth. And so although there is this relationship between your own natural oxytocin levels and depression, it's unlikely that Pitocin could impact PPD because it cannot cross the maternal blood-brain barrier. However, it could theoretically send some feedback signals through we talked about the downregulation of receptors, but that would most likely be a short-term effect. Unfortunately, the research we have on this is very poor quality. There was one systematic review in 2020, and they basically concluded we don't have enough evidence to draw any conclusions on Pitocin and postpartum depression. And then there was one study that got a lot of media attention. And again, it was just like the autism research. It was a really bad study. I read it. I saw all these red flags. I don't know how it got published. It is by Kroll and Desrosiers, and it got media attention, and a lot of birth workers are telling everybody about, don't have Pitocin or you'll have postpartum depression. And that study, I'm trying to remember, they didn't even know what kind of, how much Pitocin you got. If you just got a small shot of it postpartum or whatever. And then there was they didn't measure family history and your own personal history of depression. Just okay, if you're studying depression, you need to find out if they've had depression before. They didn't do that. So I would not consider that study, worth the paper it's printed on. It's sometimes you find this in obstetrics. I originally came from a different field of research. And sometimes in obstetrics, Erin and Ihotu, have you had this where you read a study and you're like, how did this make it past peer review? This is a terrible study. And sadly, a lot of people, they just read the summary. They don't actually download the whole study and read it. And so that's what we try to do at EBB and then summarize it for you. So it's all publicly available. If you have questions, a lot of people are like, tell me more about Pitocin in the third stage of labor. We have a whole podcast episode on that. Just Google evidence-based birth third stage and you'll find. And if it's too big a topic, that website page has a one-page handout for free that is super simple, kind of breaks it down. So thank you all for attending tonight. I think that's it. We just need to give you all the handout. So Shantae, if you could drop the link to the handout and then people can try downloading and see if it works. If for some reason you can't get it to work, we will email it to you afterwards. So just give us a minute, I think till tomorrow morning to get that email out. We will also email out some of the resources, the link to the sale, all that sort of thing. So yeah, you can get your free handout in the chat. We'll keep dropping that link as it keeps getting covered up. Also, don't forget about the sale. It's going on through next Tuesday, I believe. So you kind of have up until then to make up your mind if you want to join or not. And yeah, we are super excited that so many people were interested in learning about this topic. I think we had close to 800 people here at one point, which is really incredible when you think about, I know, Erin and you two are like, I just gave a talk in front of 800 people.
It was fun.
It was fun. Yeah.
It
If
was.
there's anything you all, particularly appreciated about tonight's webinar, let us know in the chat. We always love getting feedback. It has taken us, we have spent a lot of time putting this together for you all. So I hope you enjoyed it. I hope you learned something new and that you enjoyed the advocacy role play, that you get the handout. It has that advocacy role play in there with the scripts that the partner used, which were so well done. And all the references are in there. There's pages of references. So if you want all the, study names and journals and everything, there's several pages of those. So thank you, everyone. You've been
Thanks,
wonderful.
everyone.
Thanks for taking the time to learn more information and to empower yourselves with evidence. Bye, everyone.
Bye.